We'll now be starting our discussion on cardiovascular diseases and orientation to claims. So very first thing is I would like to do certain acknowledgements to a couple of my colleagues who have helped me in short time since I am outside Pune for my exams. So acknowledgements to Dr. Aparna, Dr. Milin, Dr. Sarita and Dr. Jyoti, who have helped me in adjusting the slides and the protocols so that we could cover this highly complicated topic in 1 hour time. So ideally, it is said if you are a cardiovascular professional, then within 6 months, you are able to buy your BMWs minimum. So that's the extent of benefits which happen to cardiac physicians as well as cardiovascular surgeons. So whether it is a cardiologist or a CVTS surgeon. So it takes only 6 months for these people post their post-graduation and specialization to establish themselves uniquely. And that is where the importance of understanding how to manage these claims comes in, because you have to control these claims properly. So a little background, because I can see most of the audience is not medical professionals. So we have seen this heart diagram many a times in our life. So just keep it at the back of your mind. Don't go into the anatomy which I'm showing there. What is important in that anatomy, I'm going to be covering in next slide. But what we need to understand here is what are cardiovascular diseases. So basically, it's not only heart, it's a group of disorders of heart and blood vessels together. So common would be, say, the coronary heart disease, wherein the blood supply to the heart muscles is compromised. So you are seeing these muscles here at the periphery. Second would be cerebrovascular disease, wherein now the supply to the brain is impacted. Or peripheral arterial disease, wherein supply to my limbs is affected. Rheumatic heart diseases, wherein there is a damage to the valves or the muscles because of rheumatic fever. It is one of the bacteria. Congenital heart diseases, where there are defects, they are developmental. Or there could be something like as simple as deep vein thrombosis and pulmonary embolism. So clots, which unfortunately can simply dislodge, get lodged in your heart, lungs, brain, and create havoc. So all this comes under cardiovascular diseases. But considering the paucity of time, we'll concentrate more on the heart diseases. So I have created one umbrella, if you see in the left bottom corner here. So all these are the nomenclatures which you will get in your claims. Coronary artery disease, coronary heart disease, ischemic heart disease, cardiovascular disease, pulmonary heart disease, hereditary heart disease, hypertensive heart disease. These are all nomenclatures. 75% of the time, the pathophysiology and how we control it or how we treat it from a claims perspective is going to remain one and the same. So whatever you get on your claims paper, just read it, but remember what I am saying next. So coming to the pathophysiology of cardiovascular diseases, most of the time it is arising either out of a plaque, so which you can see here in the left side of the diagram. So I have just opened up this artery here. So here you will see a plaque which is deposit which is happening on the blood vessel walls, or it could be a blood clot like here, this red here. So because of these two things, you can see there's a stricture which is happening now. So here where the cut has started, the lumen is bigger. Where the cut has ended, the lumen is bigger. But here, because of this plaque and this blood clot, the lumen has got constricted. And the result is, as it would happen in your common kitchen drain, no further flow. Your sink water is not going down, so it gets accumulated. Similarly, your blood flow is not going to go down to the particular part. So no nutrition, and because of no nutrition, no oxygen, that particular part at the cell level is going to be damaged and create problems. And that is why in this picture you will see he is coughing. Oh, give me blood, give me oxygen, give me oxygen. That is what he is trying to say. That's the routine pathophysiology of almost all the diseases at the artery level or at the valve level, or it could be hereditary in nature, or the muscles which are here at the outside of the heart, they are becoming weak, so pumping is not happening. Symptoms would be chest pain, which is called angina pectoris because it's on the pectoral muscle, and angina is pain. It could be myocardial infarction, diaphoresis, where you have these visual issues. There would be ECG changes, dysarrhythmias, your heart is not beating properly, chest heaviness, dyspnea, you feel shortness of breath, fatigue, because that proper oxygen is not going, you're not getting that energy. So these will be very, very common symptoms. In case of stroke, the symptoms would be sudden weakness, either of the face, arm, leg, any one side of the body. And other symptoms would be numbness, confusion, difficulty in speaking or understanding, slurring of speech, difficulty in seeing with one or both eyes, difficulty walking, dizziness, loss of balance, headache without any known cause, and fainting and unconsciousness. So any of these would be indicative towards a stroke. Others you may find pain, discomfort in arms, nausea, vomiting, but those are irrelevant symptoms. So whenever you are getting claims, you have to look at what was these symptoms talking about, because each of these symptoms gives us an idea what is the predisposing factor. Now, one of the commonest reasons why we study cardiovascular disease from claims perspective is, one, they are very high cost, and two, they contribute significantly to abuse and frauds. In Indian insurance sector, for retail commercial insurance, pre-existing diseases or complications arising out of pre-existing ailments are not covered. But people generally buy policies because they are seeing कि इतना ज़्यादा cost is of hospitalization. And the moment they find that something is coming up, their friend, relative, agent tells them, this much bill will come, you take insurance now. And they will take insurance. They'll hide the history. And then when the evidence, when the episodes come, if there is no waiting periods applicable for that particular plan, we end up in the absence of evidence to the contrary, paying up. But what we miss here is the medical opinions. What the adjudication findings have to be based upon is also on your medical documentations and medical diagnostic evidences. So there are serial investigations which generally happen, diagnostic investigations. I'm not talking about the field investigations. So you have to be looking at it, how that change is sequentially happening, and that when correlated is an admissible evidence in a court of law to prove something arising out of a predisposing factor. Besides your research papers, which are also acknowledged even in ombudsman forums and courts of law. So looking at predisposing factors is important. My chest pain, I may have started having this chest pain history quite earlier. So maybe interactions in an audiovisual format with the relatives, with the general practitioner of the person would give you an indication. Your infarctions are not happening all of a sudden there are predisposing factors for it. ECG changes, it would not be a sudden only T wave inversion or ST elevation. There would be a history attached to it. Look at the Q wave as well. But we end up seeing only ST inversion, T wave, or T inversion and ST elevation. Even the doctor has written that thing, hey, isko, pay it off. But look at the other part of the ECG aspect. Having good ECG readers in a TPA industry, in the adjudication team, is very important. Then only you will be able to understand these pathophysiological implications. So the team needs to be aware of certain diagnostic tests. ECG very common. So I have seen certain TPAs that before they have their team going for actual adjudication, in the last 10 days of their training sessions, they are trained intensively on reading ECGs, 2D echoes, blood tests, and angiography reports. Because these make a lot of difference when they actually go on the adjudication, they work as adjudicators, because then they are fresh with what they have to see. In our medical schools, in our very first day, generally across all medical colleges, it is anatomy, and the anatomists generally say, the eyes do not see what the mind does not know. So that's also standard statement on Cunningham as well. It's like a Bible we use for anatomical dissections. The eyes do not see what the mind does not say and know. And that is something I have seen being inculcated in training programs of most of the good TPAs and private insurance companies. So today when you are seeing these things, tomorrow if you are going to be seeing the claims, you will be looking at it from a different angle, because now your mind is doing these things. That is why reading ECGs, ability to understand how to differentiate angiography reports is important. So whether the disease is a valve disease or an aneurysm or a arrhythmia or a cardiopathy or a pericarditis or a heart failure or a coronary artery disease, everything is going to reflect on your ECG, which is the graphical representation of the electrophysiological impulses which are happening in your heart muscles. That is why ECGs are important. Second is your angiographies. So just do not blindly believe on what you get in that graph paper, which is shown by the cardiologist. Many times it is exaggerated. Please always ask for the films. That's very important, because there you will actually see what is the percentage of occlusion and what is the length of occlusion. So your further interventional treatment is going to be determined by your percentage of blocks and your length of blocks. Whether it is 1 stent, 2 stent, 3 stents, whether it is 10 mm stent, 20 mm stent, or 2 stents of 10 mm each. So you have to be careful about it. Then positive PET scans are done, CT scans are done. Stress test is something which was being done historically. Nowadays, the frequency has come down, I have seen, because of these advanced test CT NGOs and MR NGOs which are now available. Third, we have to ensure that whatever information is there, we correlate and analyze, especially cardiovascular diseases. Always keep this in mind. There is an information asymmetry in healthcare. There is an information asymmetry. So you have to be careful. So always for any cardiovascular disease claims, after you have gone through that 9-step ladder, which we have seen in the first part of this lecture today, we have to now talk about these 5 additional things. Correlate, analyze, and read between the lines. How the history is written, how the examination findings are written, what the care plan is, and what the reports are suggesting. Because it creates a lot of difference on how it is handled. Second part is you have to now rule out your pre-existing and predisposing factors. So it is possible on the basis of your history and your older diagnostic investigation reports, pre-hospitalization diagnostic investigation reports, and your current hospitalization diagnostic reports. So when all these three are put together, you will be able to rule out the pre-existing diseases. Then you look at the global standard treatment protocols. So within the software that you have, your claims adjudication systems that you have, your decision support systems that you have, you should be able to understand the treatment protocols. And then arrive what is better and what is worse. So if you follow this questionnaire system, the chances of mistakes happening are very less. So let us now go into these few of the commonly occurring procedures. The very first thing that we are seeing is now the PTCA, percutaneous transluminal coronary angiography. So go through this picture on the right side. So you will see there is this vessel, there is this plaque here. Okay, and here now you have put in this guide wire which has a balloon on it. And then on that guide wire, after the guide wire has come out, you have inflated the balloon. So this has pressed upon the plaque. At times it breaks it, you snatch it out, and then it is balloon angioplasty. At times it is not possible with this. So on this same guide wire, you would be putting in a stent. That stent will come here. It will be placed here, and then the guide wire will be removed. And this stent will now make this, what I'll say, passage clear. That is as simple as I could make about what is PTCA, angioplasty. But here what we find is abuses happening. Abuse by nomenclatures. Because PTCA was one of the earliest procedures to be packaged. But then the hospitals have found ways of abuse. And the commonest is PAMI. They say we have not done PTCA, we have done PAMI. What is PAMI is primary angioplasty in myocardial infarction. Procedure is same, only the difference being PTCA is your planned treatment and PAMI you are doing in an emergency setup. The moment there is an ECG change, your cath lab is available, your cardiologist is available, you immediately take up the patient up, do emergency angio, you see there is a block, you put in a stent, that's it. So what is different here is that there is a speed and there is a overriding effect on your other planned therapies. Hospital was not incurring any other expenses besides this. That is PAMI. But still, hospitals say हमने PAMI किया, it is not PTCA. They give the explanation, and someone who is new in the TPA, he approves it. And the loss is incurred by the insurance company. And even in the audit, when they have raised this query, the TPA responds to it, the insurance company auditor accepts it, and everything is under the carpet. Rotablation assisted PTCA, ROTA. Now what ROTA basically doing, it's an additional machine. So it's rotating and removing this plaque. Yes, it requires additional expenditure. That machine is costly. But what are the indications? Was our patient having those indications to go for ROTA or not? Or just because he is an affording patient, ROTA was allowed? These questions come up. And at times you ask for PTCA, but what is actually done is only balloon angioplasty. So just a guide wire, no catheter was used. Or just a balloon, one balloon, not more than that. But then because this is L2, you find they are billed extra. So you have to be careful. So to summarize, for PTCA, you will be looking at your indications, which will be patients with stable angina symptoms who are not responding to your medical therapies. So if you go through the website of jivandai.gov.in, that is the Maharashtra state scheme for the residents of Maharashtra, you will find a very wonderful collection of your standard treatment guidelines. And there they clearly tell that unless there is failure of your medical therapy with the conditions, then they will not be paying the PTCS. Emergency PTCA, that is PAMI. Occlusions, if it is 100% or ideally anything above 70%, then ST elevation, myocardial infarctions, you go for it. At the cashless level, you ask for certain documentations, important of which are your cardiac enzymes, coronary angiography reports, as well as stills and ECGs. And at the reimbursement level, you would like to ask for your barcode, post-stenting angiography stills and flow, so that the TIMI flow is established level 3, and the procedure notes, cath lab notes. CABG is again the same thing, only difference here being that here you will, instead of going in for say angioplasty, okay, I have not put in the proper picture here. Going in for the angioplasties, here you will be having the bypass which is happening. So you'll be taking a particular vessel from another part of the body and suturing it here where there is a block. The indications are going to be nearly same. Important indication here would be failed PTCA and triple vessel disease or more. So it is up to 3 blocks in the heart. Then you allow PTCA more than or equal to 3 blocks. You generally recommend to go for CABG. What is going to be different as an investigation requirement in cashless as compared to PTCA is going to be a chest X-ray and 2D echo post procedure. So those are the 2 things which will be different because you would like to see the sternal suturing. Valve procedures, so it could be single valve replacement, double valve replacement. Abuse here happens because you have 2 procedures. One is only a repair and one is a replacement. So in replacement, you are using a prosthesis. In repair, you are just repairing it, suturing it, adjusting the location. The indications would be regurgitations or stenosis, which is happening, degeneration of the valves, or previously put in prosthetic valves, or dysfunctions. What you ask here for is compulsorily your 2D echo and Doppler reports. And post-surgery, you ask for your additionally barcodes and post-surgery echo reports as well. Congestive heart failure is one of the commonly occurring conservative claims. So it's a medical management. Here there is a heart failure. So it occurs when the heart muscle does not pump blood as it should. So there is a backlog collection. It creates pressure on the heart functioning. And that is why you go into congestion. So you will see the difference in the pictures. There is a thickening of the ventricular chambers. And the filling capacity is reduced internally. So that is why it becomes weaker. Your functioning becomes weak. Indications will be shortness of breath, reduced ability to exercise, irregular heartbeats, and low ventricular ejection fractures. So left ventricular ejection fractions are going to be lowered. In these cases, in cashless, when you are taking an adjudication decision, you will be looking for clinical notes with HOPI, vital examination findings, ECGs, 2D echo, if possible, maybe a CT or a MRI or a PET scan. So that will give a definitive indication of CCF. At the claims level, besides what you have asked for at the claims level, you will also be asking for your other reports. So other common claims that you have to be worried about is your accelerated hypertensions or the thromboembolisms. So here again, you are looking for those same things which you find here. So at your investigation levels, you have to be very careful whether the indications are being fulfilled. Well, generally, just for investigation purposes, you will find that a person with a high BP is hospitalized without even a trial of giving him a sublingual depin, allowing his BP to come down, and then going into diagnostic investigations to find the causative factors. Yes, you require hospitalization if there is a blurred vision, there is difficulty in breathing, there is a severe headache and your fundoscopy report are showing your changes in exudates. In those cases, you require a hospitalization. Otherwise, the patient can be managed on OP basis. So it is one of the most commonly abused OP to IP conversion that we come across in the claims part in cardiovascular diseases. So we have to be very careful. Thromboembolism, it's an emergency. So you will have unexplained shortness of breath, rapid breathing, and very high heart rate. So you definitely need to have a CT or pulmonary angio asked for. And then you will get to the diagnosis. Yes, there is an embolism. The person has to be hospitalized. Anti-embolytic treatment has to be started. So investigation reports, treatment protocols is something which will be asked for in this particular thing. So to summarize, there is a change which has happened in the 21st century. Whatever was the change in the last 10 years, it has been more than what was there in the last complete century. And it is very rapid and which is requiring technological management. So be it providers, patients, government, everywhere it is linked. So you have these encoding softwares, case mix systems, medical record abstracting systems, billing systems, decision support systems, clinical systems. So when you're getting these claims, you have to ensure that wherever there is even a small doubt, you have your investigator who is trained on all these systems, on what to look where. He is activated. And after going through these systems, he'll get the evidence of the fraud and abuse which has happened for these cardiovascular diseases. The clinical protocols have to be monitored because the hospitals who are treating, they would be having their own protocols. So if they have shown a treatment X being given, then definitely there was that reason, the protocol which got satisfied, and that protocol is something which would be on the basis of predisposing factor, which they may have hidden on the paper here, but when they have come to this decision, it was a part of it. So when you are putting both together, you know the abuse is there, you question it, you get the answer, and you make the person aware that this is something which is not good, because finally this contract was on the basis of utmost good faith. So have the people trained on all these things, and then only they'll be able to see it. There is a huge potential, multiple new avenues, and you have to keep looking at it. So that is how you will be able to manage the cardiovascular claims. I am throwing the session open for any questions which you may like to ask. Whatever questions you may like to ask. I have also shared my WhatsApp number and my email IDs. So you may get in touch with me anytime regarding anything, any help you may require, any decision support you may require for anything. I am a servant of the industry and available all the times for the industry. So please do feel to contact me anytime you want for any kind of support that you may require from my end.